everyone. We are beginning to talk about lipids. This is week 1 in 3 weeks of talking about lipids. Today we're going to start talking about their classification and functions as well as digestion and absorption. Okay, so here are our learning objectives: to understand the basic definition of lipids as well as their functions, explain chemical classifications of fats, and the different forms of phospholipids. Okay, so lipids are primarily composed of carbon and hydrogen, but barely any oxygen, which is different from the carbohydrates that we've just talked about. And this makes fats highly hydrophobic and insoluble in water, though they are soluble in organic solvents. Because they go further in the oxidation process compared to carbohydrates, they contain more calories, so they have a lot more hydrogens that can be utilized for energy production. So this makes them a lot more dense calorically, and we know that compared to carbs and proteins, which have 4 calories per gram, fats are more energetically dense with 9 calories per gram. They also contain essential fatty acids that are needed for the absorption of our fat-soluble vitamins. So our dietary guidelines, we're kind of still between 2010 and 2015, but the guidelines recommendations are basically derived from evidence that shows us that these certain dietary practices are associated with decreased risk of chronic disease, especially cardiovascular disease, but still give us an adequate intake of essential nutrients. So we are seeing a shift in dietary guidelines where the quality of fat is emphasized more than the quantity, especially in the draft of the 2015 dietary guidelines, which aren't really out yet officially, but there's a focus on limiting animal fats, which tend to be more saturated, with the exception of seafood. The recommendations or the guidelines recommend less than 10% of calories from saturated fatty acids. They recommend that we replace solid fats, which are typically saturated, with oils that are mono or polyunsaturated. The recommendations for health benefits are that we limit trans fats as much as possible and limit cholesterol intake to less than 300 milligrams a day. So we have a higher proportion of calories from fat in younger ages because they need these for brain development and growth, but as we move toward adulthood, our recommended ranges are just 20 to 35% of calories from fat. Okay, so in the US, we're doing okay with those recommendations. Our average intake is at the upper end of the recommendation at 34% of calories from fat, and this has changed little in the last 20 to 30 years. Our average saturated fat intake as well as our cholesterol intake is slightly higher than the recommendations. However, 19% of our calories are from solid fats. However, our trans fatty intake has decreased drastically since 2006, when mandatory reporting on the when there became the need for mandatory labeling of trans fatty acids on food labels. So as consumers became more educated, our intake decreased. And then these figures just show where our saturated and solid fats are coming from. So our saturated fats are coming from cheese, pizza, and grain-based desserts primarily, and pretty similar for our sources of solid fats in this country. So grain-based desserts, pizza, and cheese. Okay, so now we're going to talk about the major types of fats, and we're really just going to focus on those that we utilize as dietary sources of energy. So we have our simple lipids, which are our fatty acids, just our saturated, unsaturated, trans fatty acids. And I think we all know that for saturated fat is saturated with hydrogens, no carbon double bonds, whereas an unsaturated fat contains at least 1 carbon double bond and therefore is not saturated with hydrogen. We then have when the fatty acids are built into and attached to a glycerol backbone. We have tri, di, or monoacylglycerols. And throughout this lecture, I will probably use triglyceride instead of triacylglycerol. They really mean the same thing. Triacylglycerol is more of kind of the chemical term, but they can be used interchangeably. And then also with simple lipids, we have our waxes, which are sterile esters and non-sterile esters. So the numeric designation for fatty acids comes from the number of carbon atoms in the fat and the number of sites of unsaturation. So we'll see this kind of format here, really. So one example is palmitic acid, which has 16 carbons in the fatty acid and 0 sites of unsaturation. So we know this is a saturated fat. Okay, we also have compound lipids, such as our phospholipids, glycolipids, and lipoproteins. So all of these are present in our plasma membranes. Phospholipids include phosphatidic acids, plasmalogens, and sphingomyelins. Glycolipids are carb-containing and often used for cell signaling, and we can see one of those over here in the plasma membrane. And lipoproteins are lipids associated with proteins, and we'll talk about them a lot today. And then third, we have our derived lipids, which are derivatives of fats, but still maintain the general properties of fats. So fats are our most efficient form of storing energy in the form of triglycerides, and because they're so energy dense in that they contain less oxidized material compared to glycogen, they are able to store energy very efficiently in a kind of space-saving type of, as space savers basically. So you need less to store more energy. Fats are also precursors for other lipids that are necessary for biological functions, such as cholesterol and phospholipids, and both of these are integral parts of the cell membrane and perform vital functions of the cell. And then fats also help to insulate us and pad our skeleton and vital organs. So not only do they protect, but they help us maintain our body temperature. Okay, fats are also needed to synthesize certain molecules that are very essential for normal body functions, such as prostaglandins, which have a role, which have like hormone-like actions, leukotrienes, which are inflammatory mediators, and thromboxanes, which are vasoconstrictors and facilitate platelet aggregation. So we'll be talking more about that moving forward, but just know that fatty acids are needed to synthesize these molecules. Cholesterol is important in forming steroid hormones and vitamin D, and our dietary fats also contain essential fatty acids needed for synthesis of biosynthesis of certain molecules in our bodies. So the main dietary form of fat is triglycerides. And here we have a triglyceride molecule. So it has a glycerol backbone with 3 esterified fatty acids. So you can see what an ester group looks like here, and you can see that we have 3 of them on this triglyceride. Okay, so fatty acids are stored for future use as triglycerides in all cells, primarily in the adipose tissue. And in other tissues in the adipose tissue, the major building block for triglycerides is glycerol. However, adipocytes lack glycerol kinase to transform glycerol to one of our intermediates for triglyceride synthesis. So instead, adipocytes must use DHAP from glycolysis as a precursor for triglyceride synthesis. So in order to build triglycerides, adipocytes must have glucose to oxidize in order to build these triglycerides from fatty acids, because they have to have the DHAP. And this process does occur to a lesser extent in other tissues. They mainly rely on glycerol. Okay, So this figure is showing the steps for triglyceride synthesis. So here I just kind of inserted, we have in other tissues, such as the liver, we have glycerol kinase, which starts us on our pathway for triglyceride synthesis. But we use DHAP from glycolysis in adipose tissue to build our triglycerides. So the glycerol backbone in other tissues, such as the liver, of triglycerides is activated by phosphorylation at the C3 position by glycerol kinase in order to produce G3P here. For fats, we utilize DHAP for the backbone, and that's carried out through the action of glycerol 3P dehydrogenase and requires NADH. Okay, so in both of these steps here, after we get to G3P, fatty acids for triglycerides are activated by two acyl-CoAs with acyl-CoA synthetases. So this isn't shown here, but basically this is what's happening here, where we have our CoAs that are activated. So two acyl-CoAs are esterified to G3P. So G3P, we have two CoAs that are esterified to G3P to yield phosphatidic acid, and another name for phosphatidic acid is 1,2-diacylglyceride phosphate. So we have a monoacylglycerol here, and then it becomes a diacylglycerol. Then we remove the phosphate from the phosphatidic acid, or 1,2-diacylglycerol phosphate, and we are left with 1,2-diacylglycerol because we've taken off the phosphate, and this serves as the substrate for the addition of the third fatty acid to produce triacylglycerol. Okay, so now we're going to talk about phospholipids. So these you might also see called glycerophospholipids or phosphoglycerides. And these are located primarily in the cell membrane. Oops, sorry, that's a typo. And in the globule membranes in milk. Globule, not globule. These do occur in very small amounts in dietary fat, so most of them are produced endogenously. And phospholipids have a structure similar to triglycerides, except C3 of the glycerol backbone is esterified to a phosphoric acid instead of a third fatty acid. So the phosphoric acid would be either inositol, choline, serine, or ethynylamine. The C1 is typically a saturated fatty acid, where C2 is typically unsaturated, and it's synthesized by the addition of a basic group, usually a nitrogenous base, to the phosphatidic acid, or 1,2-diacylglycerol. And here are our major phospholipids that we're going to go through. We have phosphatidylcholine, and then ethylamine, serine, inositol, and glycerol. Okay, so let's first start with the phospholipid phosphatidylcholine. These are also called lecithins. They primarily either have a palmitic or stearic acid at C1, and then they also have the characteristic fatty acids at C2. And the major clinical significance of this phospholipid is in the form of lecithin let's see if I can say this, palmitoyl lecithin, and actually this lecithin here is actually a choline. And this molecule is a component of lung or pulmonary surfactant. And it's the major phospholipid found in the lining of our pulmonary alveoli. Okay, so a lot of times when we have premature infants and some occasionally full-time infants, the infants have not developed this adequate levels of this phosphatidylcholine, which leads to respiratory distress syndrome, or also called hyaline membrane disease, and it's a major cause of death in premature infants because they don't have the adequate pulmonary surfactant to be able to breathe adequately. So the reason that premature infants are most likely to have it is because these molecules are typically synthesized during the third trimester of pregnancy, when endothelial cells are converted to this molecule dipalmitoyl lecithin. So fetal lung maturity can actually be measured in amniotic fluid by measuring the ratio of lecithin to sphingomyelin. So lecithin is kind of our end product here, and with a ratio of less than 2, we have, so the lecithin has not been, or the sphingomyelin has not all been converted to lecithin, we have increased risk of respiratory distress syndrome. Okay, and then we have more phospholipids, so phosphatidylphenylamine, phosphatidylserine, and phosphatidylinositol, PI. So phosphatidylinositol is present in membranes at varying levels of phosphorylation of the inositol, and this molecule is very important in signal transmission for cell growth and differentiation intercellularly. We also have phosphatidylglycerol and diphosphatidylglycerols. So both are found in high concentrations in mitochondrial membranes and also as components of pulmonary surfactant with the PC. Phosphatidylglycerol is a precursor for diphosphatidylglycerol, which is and one type of the diphosphatidylglycerol is cardiolipins. So cardiolipins occur in the mitochondrial membrane and are important for enzyme function in mitochondrial energy metabolism. DPG is a very acidic phospholipid in which 2 molecules of phosphatidic acid are linked to a glycerol head group. So we have 2 phosphatidic acids instead of just 1. Okay, so the degradation of phospholipids are catalyzed by phospholipases, and we'll see that lipases indicate degradation of an enzyme that degrades lipids. These phospholipases exhibit substrate specificities for different positions on the phospholipids, so they work very specifically. And the products of phospholipases are called lysophospholipids. So one of the most important phospholipases is phospholipase A2, which is responsible for the release, here we go, it's right here, release of arachidonic acid from the C2 position of phospholipids. And this really allows us to free the arachidonic acid, which serves as a precursor for other important molecules such as prostaglandins and leukotrienes. Okay, and then we have our ether phospholipids. So instead of an ester bond, we have an ether bond. And these include plasmalogens. So these are complex membrane lipids, except they have at C1 instead of, they have a different kind of bond. So an O-alkyl or an O-alkenyl ether species. And plasmalogen classes include choline, which can be found in the cardiac tissue, ethylamine, or found in myelin or serine plasmalogens. So again, we kind of utilize some of the same substrates as for other phospholipids. So one choline plasmalogen is platelet activating factor, PAF, which is a biologic mediator that's capable of inducing cellular response for platelet aggregation. And this serves as a mediator for not only platelet aggregation and release, but as a mediator of hypersensitivity, acute inflammatory reactions, and anaphylactic shock in tissues throughout the body. Okay, so I think we're all pretty familiar with the benefits of saturated versus unsaturated fatty acids, but let's just kind of review them quickly. So we know that total fat, saturated fat, cholesterol, and trans fats are positively correlated with cardiovascular disease because they either have a hypercholesterolemic effect or they shift our low density lipoprotein, high density lipoprotein ratios unfavorably. So some examples of this are lauric, myristic or palmitic acid, and our fatty acid that has the 14 carbons, this myristic, is very potent hypercholesterolemic and raises LDL cholesterol most potently. So conversely, mono and polyunsaturated fats have a negative correlation with cardiovascular disease because they either have a hypocholesterolemic effect or they shift our ratios of cholesterols favorably. So this really only works though if we consume MUFAs and PUFAs instead of our saturated fats and trans fats and cholesterols. So if we just ate more fat but we weren't getting rid of the unfavorable fats, then we really wouldn't see these effects. So MUFAs and PUFAs work together. The MUFAs really need the PUFAs to have their these kind of favorable outcomes. And linoleic acid, which is an omega-6, in adipose tissue, we know is inversely associated with risk of cardiovascular disease and is potent independently lowering total and LDL cholesterol. Okay, and then we have our omega-3s, which we all know have many anti-atherogenic properties. So first, they interfere with platelet aggregation, which keeps kind of our keeps our blood pressure low, kind of keeps our blood flowing more effectively and oxygen being delivered more effectively. Omega-3s also decrease the release of pro-inflammatory cytokines from cells involved in fatty plaque formation. So decreases our overall body inflammation, and it also reduces these intake of omega-3s can also reduce triglyceride concentrations in our blood by over a quarter. So then we have our trans fatty acids. So there is a small amount of trans fatty acids that we find naturally in the diet, but usually they're more chemically derived from hydrogenation of PUFAs or MUFAs. And the most abundant trans fatty acid we find in the diet is aleatic acid. I think I said that one right. So basically, we can see just a comparison in here. We have the oleic acid with our double bond here, and then we have our hydrogens on one side, so that's the cis formation, whereas for this trans fatty acid, we have our double bond and our hydrogens are on the opposite side, so that's a trans bond. Okay, so you can go through the practice questions, but I'm just going to move forward to our next topic, which is digestion and absorption of fat and lipoproteins. So our learning objectives for this section are to describe the digestion of dietary lipids, including roles in the mouth, stomach, jejunum, pancreas, liver, and gallbladder. Describe absorption of dietary lipids into the enterocyte and mechanism for appearance in the blood. Extrapolate on the effect of varying circumstances of digestion and absorption of dietary lipids, and identify major components of lipoproteins. So the main beginning of digestion of fats in our mouth is mechanical. So and in our stomach is kind of this chewing and churning, which helps emulsify the fats, even though they are insoluble in a watery solution. So in our mouth, though, we also do have an enzyme secreted, which is lingual lipase. And this particularly acts on short and medium chain triglycerides. And lipases in general hydrolyze lipids. So this lingual lipase is no different. And so we have some hard fats that do begin to melt in our mouth. So it's kind of just the beginning, but it's a very small role in fat digestion in adults, though it does play a more active role in infants, especially because they do have more short and medium chain fatty acids found in milk. Oh, and I should say, going back to this, that I know I said earlier, but the major lipids that we find in a typical Western diet are triglycerides, though we do find some phospholipids and some sterols and sterol esters. Okay, moving on to the stomach. Lipid digestion is initiated by hydrolyzing triglycerides into diglycerides plus a free fatty acid. Again, our stomach kind of does this mechanical churning, which helps to break up the fat. And gastric lipases, again, play kind of a minor role in fat digestion, but they do hydrolyze a small amount of fat. And then we're going to move on to the small intestine, where we have our major action of fat degradation. So secretions from bile secretions and pancreatic secretions are needed to digest and absorb lipids in the jejunum. So these are secreted right into the small intestine. And when the fat enters the small intestine from the stomach, it signals the release of cholecystokinin, which signals the gallbladder to release bile, which emulsifies our fat. So the presence of fat stimulates bile, which can emulsify that fat. And both pancreatic and intestinal lipases play the most important role in the digestion of triglycerides to monoglycerides, glycerol, and free fatty acids. Okay, so bile is synthesized in the liver, but it's stored and concentrated in the gallbladder. So it contains cholesterol, phospholipids, and bile acid. So at one end of each bile, there's a side chain of amino acids that are attracted to the water, and at the other end is a sterol that's attracted to the fat. So here it's kind of tricky because it looks like we're hydrophilic on both ends and hydrophobic in the middle, but just kind of try to, in your mind, think of it as the hydrophobic being on top and the hydrophilic being on the bottom, because it's more of like kind of a disc, and it's kind of a the molecule is not flat like this, it's 3D. Okay, so because they have because they're amphipathic, they are both hydrophobic and hydrophilic, they act like detergents, which allow the better mixing of lipids and non-lipids. And bile emulsifies these large fat globules so that they are emulsified into smaller droplets that repel each other. And because they are in these smaller droplets, there's more surface area that has access to the enzymes, these lipases, that will help to break down the fats. Okay, so our pancreas is very important in fat digestion because it secretes a lot of lipase enzymes, phospholipases, cholesterol, and cholesterol esterase, all which are needed to release fatty acids from lipid. So the pancreatic lipase degrades triglycerides at the 1 and 3 position, so in yielding 1,2 diacylglycerols and 2 monoacylglycerols. Phospholipases degrade at the 2nd position by pancreatic phospholipase A2. So we already talked about that, releasing a free fatty acid and lysophospholipid. And the cholesterol esterases hydrolyze to free cholesterol, and this enzyme cholesterol esterase is activated by bile salt. Okay, so just to summarize what we've talked about already, in the intestinal lumen, with the help of pancreatic lipase, triglycerides are degraded into 1,2 diglycerides, and then to 2 monoglycerides and then to 1 monoglyceride and glycerol. And then once we have our, so let's see here. So we have our triglycerides, we have our bile salts and our lipases from the pancreas and gallbladder. And so then we have degradation into the monoglycerides and our fatty acids. And then these bile salts, along with the monoglycerides, fatty acids, and some diglycerides and lysophospholipids and sterols, form a micelle. So these micelles are small enough. We've broken down our big flat globules enough to micelles that are small enough to be absorbed between the microvilli. Okay, so then the micelles go through here, and then we have basically this is the mechanism by which fatty acids and monoglycerides can enter the enterocyte. Okay, so we know that lipids are poorly soluble, so they have to be solubilized by a biologic detergent, in this case the bile acids, which are again produced by the liver and converted to bile salt. Okay, and then so the bile salts become our detergent that make lipid absorption possible. So micelles really shuttle the products of fat digestion from the site of digestion in the intestinal lumen to the brush border, where they can be absorbed into the enterocyte. Then the micelles are broken back down into their constituents of glycerol and fatty acids, which then recombine to triglycerides and are incorporated into chylomicrons. So the glycerol and fatty acids are packaged into micelles. That helps them be absorbed into the enterocyte. Then they kind of leave the micelle as free again and then recombine to form triglycerides to go into chylomicrons. And then the chylomicrons are transported to the lymph system, where they then enter blood via the thoracic duct. And so from the lymph system to the blood, as a chylomicron, that begins about 1 to 2 hours after the meal. So that's how long it really takes to digest in a healthy individual. Okay, so here's just an up-close look of how the constituents of a micelle are absorbed into the enterocyte. So we have our micelle formation, and then we have micelles that are so small they can kind of get in between the microvilli, where the free fatty acids and glycerol are then able to passively diffuse into the enterocyte, and then once they pass through, then they kind of reconvene into these triglycerides. Okay, so we just said that the lipids diffuse across into the enterocyte mostly as monoglycerides and free fatty acids, and then when they go to the enterocyte, then they're reesterified into triglycerides. So then kind of some of our other constituents of the micelle, lysophospholipids, are reesterified into phospholipids, and cholesterol is reesterified into cholesterol ester. So basically, we're breaking them down. They're going to allow them to diffuse into the enterocyte, and then we're kind of putting them all back together. And then when we put them back together, all of these constituents are packaged as chylomicrons, and these go into the lymph system, and then eventually to the thoracic duct, where they're delivered to other tissues. Okay, so here's kind of an overview that I'll go through kind of quickly. So we have dietary fat is emulsified into smaller droplets to prevent them to increase their surface area for degradation by pancreatic lipase. The lipase then hydrolyzes triglycerides into monoglycerides and free fatty acids. These are then carried into these are then packaged into micelles, which are small enough to fit between microvilli, and then they diffuse into the enterocyte, where they're resynthesized into triglycerides. They're coated with a lipoprotein and then packaged into chylomicrons, which enter the lymph system. Okay, so let's just watch a little YouTube video that'll kind of clarify this.
Assemble your own team of heroes to win the battle.
Hey, cool.
With Marvel Fantasy Superheroes.
Foods, such as meats, dairy products, seeds, nuts, and oils, contain dietary fat. And fat is a common example of a lipid. And in this lesson, you will learn about the unique way lipids, such as fats, are broken down and absorbed out of the digestive tract. Now, a lipid is defined as a fat-like molecule that does not have the ability to dissolve in water. This inability to dissolve in water adds an element of difficulty to fat digestion. Because fat does not like water, it tends to clump together and form large droplets as it moves through your digestive system. By the time fat reaches your small intestine, it has not been digested at all. So dietary fat in the small intestine looks like a fairly large glob of fat. These globs remain until bile that is produced in the liver and stored in the gallbladder mixes with the large fat droplets. Now, bile contains bile salts, which act as an emulsifier of lipids. The term emulsify means to break large fat droplets into smaller droplets. And that is exactly what we see happening here in the small intestine. The bile salts break up and coat the fat to form much finer droplets. These finer droplets have more surface area, and this aids digestion because the fat-digesting enzyme pancreatic lipase can only act on the surface of the fat droplet. The enzymes of the small intestine are responsible for almost all of the fat digestion. When pancreatic lipase acts on the lipid, it breaks it down, which results in free fatty acids and monoglycerides, the two digestive products of lipids. These products are much easier for your small intestine to handle, and they have very little trouble being absorbed out of your digestive tract. Now, absorption takes place through the mucosal lining of the small intestine, and when these products pass through the mucosa, they enter the epithelial cells. Once inside the cells, the free fatty acids and monoglycerides enter the endoplasmic reticulum, which is a system inside the cell whose functions include synthesis and transport of lipids. Here, the digested products are resynthesized into triglycerides. Triglycerides are the major form of fat stored by the body. So an important fact to point out is that fats are reassembled in the epithelial cells of the small intestine. This makes fat absorption different than absorption of proteins and carbohydrates. With protein and carbohydrate absorption, we see their basic units, which are amino acids and monosaccharides, are able to pass through the intestinal epithelial cells without being altered. Now, before the triglycerides actually leave the epithelial cells, they're coated by protein, which results in the formation of chylomicrons. So we see that chylomicrons are small globules composed of protein and lipid. The coating of protein gives the triglyceride a water-soluble coat, and this allows the chylomicron to travel outside of the cell. The newly formed chylomicrons leave the epithelial cell and enter the lymphatic capillaries, which are called lacteals. The lacteals are found in the finger-like projections of the intestinal wall called the villi. The lacteals represent another unique way fats are absorbed, because lipids pass through the lymphatic system before they make their way back to your bloodstream. This differs from protein and carbohydrate digestion because amino acids and monosaccharides do not enter the lymphatic system. Instead, they travel directly into the blood capillaries and then into the hepatic portal vein that leads to the liver. Fats can now travel around your body. They are used to build cell membranes, make the myelin sheaths that coat your nerves, and of course insulate the body with a fatty cushion. Fats can also be used as fuel for your body if there are not enough carbohydrates in your system. And although you need fats for these important body functions, you can have too much of a good thing. For example, a high level of triglycerides in your blood can increase your risk of heart disease. Let's review. A lipid is defined as a fat-like molecule.
Okay, So let's move on to lipoprotein lipase enzyme. So the fatty acids of chylomicrons are removed from triglycerides by lipoprotein lipase in capillaries of adipose tissue and muscle. Lipoprotein lipase is activated by one of our lipoproteins, lipoprotein C2, and don't worry if that looks a little intimidating, we're going to talk a lot about lipoproteins, but these are found on the surface of endothelial cells in the capillaries. So we have our molecule that's needed for activation of lipoprotein lipase right in the capillaries where we need it. Now, when free fatty acids are released with the action of lipoprotein lipase, these free fatty acids can be absorbed and utilized for energy, or they can be built up into triglycerides for later use. The glycerol backbone of triglycerides is then, once all the fatty acids have been removed, we have the glycerol backbone, and that's then returned to the liver and the kidneys. So after we have the removal of the fatty acids of the via the action of lipoprotein lipase, the chylomicron is left as a remnant. So we had our chylomicron with all of our fatty acids in it. The fatty acids are taken away, and what we have left is this chylomicron remnant particle that still has a lot of, it's very high in cholesterol here. So this is indicating cholesterol ester. And it also has important lipoproteins, including apolipoprotein E and apolipoprotein B48. This remnant is then taken up by the liver via a receptor-mediated endocytosis between the chylomicron remnant and the chylomicron remnant receptor. And the recognition of these receptors so that they can be endocytized is this apolipoprotein E. Sorry, on here it's B48, but it's ApoE that is kind of the recognizing lipoprotein that allows the chylomicron remnant to be endocytized by the liver. Okay, so this figure is showing what happens to our chylomicrons basically from kind of start to finish. So we have our chylomicron that's produced in the small intestine. Then it goes into our lymph system and then into our capillaries. The lipoprotein lipase in the capillary endothelium act to free our fatty acids and deliver them to exogenous tissues, such as the adipose tissue and muscle. The glycerol then goes back to the liver or the kidneys. And we have what's left is our chylomicron remnant, which then is returns back to the liver through endocytosis. Okay. So how is this metabolism regulated? Well, the major rate-limiting step of fatty acid synthesis is this step here, from acetyl-CoA to malonyl-CoA, with the enzyme acetyl-CoA carboxylase, or ACC. And ACC activity is affected by phosphorylation. So, and in a way that really makes sense. So if we have glucagon or epinephrine here, again, our body is saying, I don't really have enough. These hormones activate the protein kinase. It's the secondary messenger system. So first it activates CAMP and then the protein kinase. And this results in phosphorylation of ACC, which makes it inactive. So basically, if I have these stress hormones or I don't have enough, my body's saying, no, don't make more fatty acids. Stop making fatty acids because we need to use what we have for energy. And then for insulin, we have kind of the opposite effect where it's independent of CAMP and PKA, but we have an enzymatic reaction here which removes the phosphate from the ACC by a phosphatase and makes it active again. So again, if we have insulin, is in response to saying, okay, I have enough, we can store what we've got present, and then that would initiate fatty acid synthesis. So here's another, just kind of another way to put it here. So So this is regulation of fatty acid synthesis by epinephrine. So this is kind of one of our stress hormones. So epinephrine binds to a receptor that leads to activation of adenylate cyclase and camp formation, which activates PKA and activates or phosphorylates and activates hormone-sensitive lipase, which hydrolyzes fatty acids from triglycerides here down to diglycerides and ultimately monoglycerides and glycerol. So the final fatty acid release here is through monoacylglyceride lipase, and this one is active actually without hormonal stimulation. But basically this whole thing makes sense. We have a stress hormone. We're saying not only do we not want to build up more fatty acids, but we actually want to break down what we have for energy. Okay, so now we're going to move on to lipoproteins and apolipoproteins. Lipoproteins are complexes of, and apolipoproteins are complexes of lipids and proteins that are held together by non-covalent bonds. And each of these has a characteristic mass, chemical composition, density, and physiological role. And each lipoprotein has a characteristic apolipoprotein that's associated with it in a certain composition or ratio. So the cores of lipoproteins are cholesterol esters and triglycerides, and the surfaces have phospholipids, free cholesterols, and apolipoproteins. So apolipoproteins are involved in the assembly and secretion of lipoproteins. They also provide structural integrity, and they activate lipoprotein modifying enzymes. In addition, they serve as ligands for a large assortment of receptors and membrane proteins. Okay, so our major lipoproteins that we find in the blood are chylomicrons, VLDL, LDL, and HDL. And these vary in their size and density and amount of cholesterol, lipid, and protein that they contain. And then an apolipoprotein coats a lipoprotein particle and serves a number of functions. So we went over some of them in the last slide, but primarily they are responsible for the transport of lipids in the blood and the recognition of lipoprotein particles by enzymes that remove lipids from the lipoproteins. So apolipoproteins coat the lipoproteins and primarily serve as recognition molecules as the lipoproteins go through the blood. So the major classes of apolipoproteins are A, B, C, and E. So let's just go through these briefly. Apolipoprotein A is synthesized in the liver and intestine and is a major component of HDL. And the specifically apolipoprotein A1 is a primary structural protein for HDL. And this type of ApoA is also effective at promoting the efflux of cholesterol from peripheral tissues, which is the first step in reverse cholesterol transport. And it serves as an enzyme for lecithin cholesterol acetyltransferase. Again, we'll see that when we talk about reverse cholesterol transport. So because this molecule is needed for reverse cholesterol transport, when we have high levels of this molecule, we have decreased CAD risk, which makes sense because if we have more reverse cholesterol transport, it would be associated with decreased CAD risk. Okay, next we have apolipoprotein B, which is, we have two important forms of that in humans. So the first is ApoB48, and we find this largely in chylomicrons and chylomicron remnants. And this apolipoprotein plays an essential role in the absorption of dietary fats and is synthesized in the small intestine. And then we also have ApoB100, which is a major ligand for the LDL receptor in the liver. And other, I think in the liver and other tissues. It's synthesized in the liver and is required for the assembly of very low density lipoprotein for transport of cholesterol out of the liver to the tissues. And it's also found in intermediate and low density lipoproteins after the removal of APO, A, C, and E. Briefly, apolipoprotein C is synthesized in the liver and intestine and is an essential component of particles rich in both chylomicrons and VLDLs. So a deficiency in apolipoprotein C2 specifically causes an accumulation of chylomicrons and VLDLs, and it's a necessary cofactor for the activation of lipoprotein lipase needed for lipid degradation. Lipoprotein E is synthesized in the liver from VLDL and released during the formation of IDL and LDL. It's produced, however, it's produced independently of VDLDL in the brain and other tissues, so only synthesized from VLDL in the liver. And its role is that it helps is that it's recognized, it's used as a recognition signal basically by the LDL receptor related protein on the LDL receptor. So basically this apolipoprotein E is necessary for LDL to be incorporated into other tissues, to land on and be incorporated into other tissues. So cholesterol can't be taken up into the cells unless the cell sees this ApoE indicator or signal. So some people don't have a genetic defect in producing ApoE, but we don't, it's kind of a complex process because we don't really see a defect in lipid metabolism just with this one specific defect. So it's not quite that simple. Okay, so we've talked about our apolipoproteins. Now I'm going to talk about one kind of special case, which is lipoprotein A. Okay, so I remember I said in our apolipoproteins, the lipoprotein is non-covalently attached to the apolipoprotein, but in lipoprotein A, we actually do have covalent bonding of an LDL particle with the apolipoprotein A. And then these also contain specifically ApoA1 and ApoE. And the role of lipoprotein A is it's linked in the lipid transport system, so it can deliver cholesterol to regions of recent injury, and it also plays a role in the blood clotting system, so it could play a role in sudden clot development. So we know that there is a correlation between increased levels of lipoprotein A and premature myocardial infarction due to the blocking of blood vessels in the heart via clot formation. Okay, so now we're going to talk about our lipoproteins. So let's start with our first step, which is the chylomicrons. So we've talked about the chylomicrons are assembled in the intestinal mucosa as a means to transport cholesterol and triglycerides from the enterocyte to the rest of the body. So these are formed from our exogenous lipids, which have been digested and absorbed into our enterocytes, and they predominantly contain triglycerides. So here's one here. You can see our cholesterol, our phospholipids on the edge, our triglycerides and cholesterols in the esters in the center here, and then our apolipoproteins, which are on the edge or surface. Okay, and we've already looked at this graph or this figure, but we'll kind of go into it in just a little bit more detail now that we have additional information. So the chylomicrons are packaged again in the small intestine. They leave via the lymphatic system and enter circulation at the subclavian vein. In the bloodstream, chylomicrons acquire ApoC2 and ApoE from plasma HDLs. Okay, So ApoC2 and E from HDLs are attached onto the chylomicron. In the capillaries of the adipose muscle and the tissue, the fatty acids of chylomicrons are released from the triglycerides by lipoprotein lipase, found on the surface of the endothelial cells in the capillaries. ApoC in the chylomicrons, ApoC2 in the chylomicrons, activates the lipoprotein lipase in the presence of phospholipids. So we need this ApoC2 in order for this lipoprotein lipase to work. Free fatty acids are then absorbed by the tissues. Glycerol backbone goes to liver and kidneys. Glycerol is converted back into the intermediate DHAP. And then also I should say that during removal of these free fatty acids, we also have removal of a substantial amount of the phospholipids, ApoA and ApoC. And ApoC is returned to the HDL. So remember, it came from the HDL up here, and we return it to the HDL. And then because the chylomicron loses its C2, then we don't have activation of lipoprotein lipase, and therefore there's no further degradation of this chylomicron remnant because we don't have the C2. And then the chylomicron remnant that contains cholesterol, ApoE, and ApoB48 are delivered and taken to the liver through the reaction with the chylomicron remnant receptor. And then remember that we needed this ApoE in order for it to be taken up by the liver. Okay, let's move on to VLDLs. So when cholesterol is consumed in excess of the body's needs, when carbohydrates and proteins are consumed in excess of the body's needs, these are then converted to triglycerides in the liver. So the triglycerides are then packaged into VLDLs and released into circulation so that they can be delivered to the tissues to either be stored as energy or stored for future use as energy or oxidized for current energy needs. So molecules are formed, so these VLDL molecules are formed to transport endogenously derived triglycerides from, because remember, they've already been all broken down. There's two different things going on here. So we have our packaging of our exogenous triglycerides that go into the chylomicrons, and we already talked about what that happens. And then we have our endogenously derived triglycerides from excess protein and fat, and then these are packaged up into our VLDL, or very low density lipoproteins. And then these are released into the delivered to other tissues such as adipose tissue and muscle through the action of lipoprotein lipase. So same as the chylomicron. So both the chylomicron and both the VLDL contain free triglycerides that are acted upon by lipoprotein lipase to deliver fatty acids to our tissues. So when we have the action of lipoprotein lipase plus the loss of ApoAC and triglycerides, we then get the conversion of VLDL to IDL. So we have VLDL, then we have the actions of lipoprotein lipase and our loss of ApoC, and we have IDL, which are intermediate density lipoproteins, or VLDL remnants. Okay, so then the IDLs are removed from VLDLs, and the rate is either conversion of LDLs. Okay, so we have VLDLs, our triglycerides are removed, it becomes IDLs, and then as more triglycerides are removed from IDLs, they become LDLs. So IDLs can actually be directly taken up by the liver, or they can be have fatty acids further removed to become LDLs. So the liver can directly take up the IDLs with the LDL receptor through endocytosis, and LDL receptor recognition of the IDLs again requires our apolipoproteins, especially apolipoprotein A. So once we have the conversion of IDLs to LDLs, we have our LDL, which is our primary plasma carrier of cholesterol to delivery to the tissues. So LDL is our primary carrier to deliver cholesterol to all of our tissues. And the LDL exclusively contains one apolipoprotein, which is ApoB100. So then LDLs are taken up by cells via LDL receptor mediated endocytosis. Okay, and this is a little bit blurry, but we've already talked about this kind of pathway here on the right, where with our chylomicron and chylomicron remnant to the liver. And then we have this endogenous pathway. So this is from all of our triglycerides that were synthesized in our liver from other sources. So we have it packaged into VLDL. Once it undergoes action by lipoprotein lipase, we have our IDL. Then that's, again, we have more action of the lipoprotein lipase and removal of free fatty acids to LDL. And then this LDL carries cholesterol to all of our extrahepatic tissues by landing on the LDL receptor. Okay, so then, so then we have, so our endosomes, so when we have this endocytized vesicle of our LDL cholesterol, we call it an endosome. And these fuse with lysosomes, which have kind of more of our enzymes for further degradation. And this results in degraded apolipoprotein and cholesterol esters that are hydrolyzed to yield free cholesterol. So the LDL is endocytized and yields free cholesterol, which is then can be incorporated into the plasma membrane of that cell if necessary. So again, LDLs are the primary carrier of cholesterol to our tissues, and kind of indirectly they deliver cholesterol from the liver to the peripheral tissues. So the cholesterol and triglycerides are packaged up in VLDL, which are ultimately converted to LDL and deliver these to the tissues. So if we have extra cholesterol, other than that was needed for the plasma membrane, it's then reesterified for intracellular storage of this cholesterol. And the enzyme that facilitates this conversion to the stored form of cholesterol is enhanced by the presence of cholesterol. So more cholesterol promotes storage of cholesterol, and we'll be talking about this more in a different week. Okay, so this is just kind of an overview of what we've been talking about, so I'll just briefly go through it. Oops. We talked about our exogenous system by which triglycerides are then delivered. And action by lipoprotein lipase allows for free fatty acid delivery to the adipose tissue. Chylomicron remnants go back to the liver, okay? And so we have cholesterol here, and the cholesterol is esterified and packaged up into VLDL. Our VLDL is then converted to IDL and LDL, and cholesterol is delivered to our extrahepatic tissues. Okay, the LDL, then we can have some, if we have, all of this excess cholesterol, it's delivered to our foam cells, which we know are an important part in the synthesis of plaques, which lead to cardiovascular disease. So our LDLs can then go back to our So our LDLs not only go to our extrahepatic tissues where they're taken up by cells, but they also go back to the liver via the LDL receptor. So, and we'll just talk about those two parts here. So our next topic that we're going to talk about is HDL and the reverse cholesterol transport. Just a second, let me see if there's anything else that I wanted to say about this here. Okay, so, traditionally we've talked about just that the quantity of our LDLs are, what's indicated of atherosclerosis. So we get our LDL levels when we go and get labs. However, this kind of idea is kind of changing, where now we're understanding that it's really the concentration and size of the LDL particles that are more indicative of progression of atherosclerosis than just the simple concentration which we normally measure. So the healthiest pattern that we find is if we have small numbers of large LDL particles compared to a more unhealthy pattern associated with atherosclerosis, which is more small, dense LDLs. And that's just because small particles are more likely to penetrate the epithelium of cells. So these small particles are more likely to deliver cholesterol to our tissues. But we've kind of got a long way before we can measure this regularly or routinely in the hospital setting. Okay, so now we're going to move on to HDLs, which are primarily protein-rich disc-shaped particles. And their main function is to remove cholesterol from the periphery to the liver. So all that cholesterol that we just delivered to our peripheral tissues through LDL, we can actually pick up and bring back to the liver with LDLs. So HDLs are with HDLs. So HDLs are synthesized in the liver and small intestine, and they are most closely associated with apolipoprotein A1. And the ratio of ApoA1 to ApoA2 determines the functional and atherogenic properties of HDL. So the free cholesterols that we find in IDLs can be esterified through an HDL-associated enzyme. Through an HDL-associated enzyme, which is called the lecithin cholesterol acyl transferase, or LCAT. And then LCAT activity requires interaction with ApoA1 apolipoprotein, which is found on the surface of HDLs. So it kind of all works together. We need the HDLs to pick up the cholesterol from the periphery, and this is possible through the enzyme LCAT, but LCAT requires the apolipoprotein that we find on HDLs. Oh, and I should say that ApoA1 is the primary protein mass. It is 70% of HDL, whereas ApoA2 is typically another 20% of the mass of HDLs, of protein mass of HDLs. So HDLs remove excess cholesterol from cells and facilitate the transfer back to the liver, where it's either repackaged back into VLDLs or, most ideally, it's converted into bile. So when the HDLs pick up the cholesterol from the periphery, they're endocytized into the liver, converted to bile, and then this bile is stored in the gallbladder, and it returns to the GI tract, where it's either recycled, as we've talked about in the past, or ideally where some of it is eliminated as feces. So in this way, we can take some of the cholesterol that we have in excess in our peripheral tissues, bring it back to the liver, repackage it up, and actually excrete some of it from the body. So that's why HDL is beneficial for decreasing our cholesterol levels, because it helps us take some of our cholesterol, repackage it as bile, and excrete it in our feces. So the hepatic uptake of HDLs is called reverse cholesterol transport. So I just mentioned the enzyme that is responsible or necessary for this reverse cholesterol transport. It's secreted by the liver and released in association with HDL, which makes sense because HDL is what we're using for this reverse cholesterol transport. And it's responsible for the esterification of cholesterol molecules to HDL. So it's what actually allows the HDL to pick up these cholesterol molecules. And again, this is activated by ApoA1 and inhibited by LDL oxidation products. Okay, so because of the mechanism that I just talked about, HDL does have an anti-atherogenic role because it reverses cholesterol transport, but also because it's picking up this cholesterol from the cells, it's impeding the oxidation of LDL cholesterol, which is essential in the stage of atherogenesis. And you can see in the previous slide that we have that it's inhibited. I don't know if it was, oh yes, that it's inhibited by LDL oxidation products. So several of the HDL-associated enzymes participate in hydrolyzing phospholipids, hydroperoxides that are generated during LDL oxidation, and those are listed here. And so these HDL-associated enzymes prevent accumulation of the oxidized lipids of LDL. And these enzymes are responsible for antioxidant and anti-inflammatory properties. Related to stopping this oxidation of LDL. Okay, and here's something that you've kind of probably seen before. So in our chylomicrons, these are largely triglycerides and are very low density lipoproteins all the way to high density lipoproteins. We have decreasing levels of triglyceride, but increasing levels of protein. And then we can see here we have our cholesterol is packaged up in our VLDL. As the fatty acids are removed, we actually get a higher concentration of the cholesterol. And then same thing for the LDL. Fatty acids are removed, our concentration is the highest of cholesterol, and then these are delivered to the tissues. Okay, so HDL is essential for the transport of cholesterol from extrahepatic tissues to the liver, and the liver is the only organ that is capable of degrading cholesterol. So it must be transported so cholesterol must be transported through the blood to the liver so that it can be processed, degraded, and secreted in the bile, because we don't really have another method of getting rid of the cholesterol from our bodies. So as I said, the cholesterol is excreted in the bile as free cholesterol, or the bile acids are formed from the cholesterol. So they could be synthesized or used to synthesize bile acids. So that's another way we can kind of use it up. So we can either use the cholesterol to make bile acids, which uses up the cholesterol, or once it goes into the bile and goes through circulation, it can be excreted in the feces. So we're using more up and getting rid of more. So let's watch a quick YouTube video about this. Again, sorry for the ad.
In honor of World Heart Day on September 29th, the National Forum for Heart Disease and Stroke Prevention teamed up with their members to
Reverse cholesterol transport is a pathway for plaque reduction. The key mediator of this process is HDL. HDL is a particle that transports cholesterol, and its production starts in the intestines and the liver. Lipid-poor ApoA1 is secreted from the liver and intestinal cells and released into plasma for circulation to peripheral cells. ApoA1 thought to be largely responsible for the anti-atherosclerotic properties of HDL, makes up 70% of the protein on HDL and is found on virtually every HDL particle. Some of these particles will reach the heart, where they enter the vessel wall and come in contact with cholesterol-rich foam cells, which are part of the atherosclerotic plaque. The lipid-poor ApoA1 protein interacts with ABCA1, thereby developing the nascent HDL particle, which then interacts with the transporters ABCG1 and SRB1 to develop into a mature HDL particle. As it contacts foam cells, HDL accumulates cholesterol, becoming a cholesterol-rich ester as it matures. The nascent and later mature HDL facilitate efflux of cholesterol from the peripheral macrophages, enabling reverse cholesterol transport. Mature HDL delivers cholesterol to the liver through two pathways, a direct pathway and an indirect pathway. Through the direct pathway, HDL interacts with a receptor, SRB1, on the liver, allowing the delivery of cholesterol. The resulting lipid-poor HDL particle can then be recirculated, where it can repeat the process of reverse cholesterol transport. HDL also passes cholesterol to the liver through an indirect pathway via cholesterol ester transfer protein, or CETP. CETP facilitates the exchange of cholesterol in HDL for triglycerides in the triglyceride-rich ApoB particles VLDL and LDL. In this one-to-one exchange, HDL is enriched with triglycerides and LDL with cholesterol. LDL particles may go into circulation or interact with LDL receptors at liver cells, where LDL particles may deposit the cholesterol ester content at the LDL receptor. After cholesterol is delivered to the liver by either pathway, it is processed or secreted into the bile and carried to the intestine. HDL plays a critical role in reverse cholesterol transport by delivering cholesterol from plaque in the peripheral macrophages to the liver, where it is processed for excretion from the body. The net effect of HDL in the reverse cholesterol transport pathway is the removal of cholesterol from plaque and the potential reduction of cardiovascular risk.
So nascent HDL, we talked about, so HDL then delivers the cholesterol back to the liver, and then we have what's called nascent HDL, which is kind of the HDL that's ready to pick up the cholesterol, is regenerated via triglyceride lipase and phospholipid transfer from the protein, and the cycle continues. So we have HDL, it picks up the cholesterol, it drops it off, and then it can be reused. Okay, I briefly want to talk about the cholesterol ester transfer protein, or CETP. So you'll probably see that it's a glycoprotein that's primarily synthesized in the liver and bound to HDL containing ApoA1 particles. And this protein does play a central role in reverse cholesterol transport by moving cholesterol from the peripheral tissues to the liver. They talked about that in that video. Okay, so what is the clinical significance of lipoprotein metabolism? Well, we know that defects in lipoprotein metabolism can have effects on our concentration of cholesterol in our blood, and so it can make us either hypo or hypocholesterolemic, but these deficiencies are rare. However, we do see it as this defect. We do see a secondary effect of other disorders that would lead to altered cholesterol levels in our blood. So, for instance, patients with diabetes or hypothyroidism or kidney disease those disorders themselves can cause abnormal lipoprotein metabolism. So in diabetes specifically, we know that lipoprotein lipase is regulated by insulin. So if we don't have enough insulin, then we may have a lipoprotein lipase deficiency, or a deficiency in the activity of it at least. And this can lead to type 1 hyperlipoproteinemia as a secondary outcome of diabetes mellitus. So we can't break it down, and therefore we can't break down the lipoproteins because we don't have the insulin to make our lipoprotein lipase work, and therefore we have a buildup of the lipoproteins in the blood. And the hypercholesterolemia that's really the most prevalent in the general population is just caused by genetics. It's familial. And in this form, we have, again, reduced LDL clearance, which leads to hypercholesterolemia and arthrosclerosis in CAD. Okay, so this is just kind of an overview of everything we talked about that you can kind of use. So let's just real quick go through this. So we have our dietary fat and cholesterol packaged into chylomicrons. Remnants of chylomicrons are delivered back to the liver. Okay, good. Then we have our endogenous synthesis of triglycerides and cholesterol, which are packaged in VLDL. These can be converted to IDL, and the IDL can either go back to the liver or can be converted to LDL through lipoprotein lipase. The LDL can then go either back to the liver via the LDL receptor or to our peripheral tissues via the LDL receptor. Here, a couple of things can happen. We can have our LCAT enzyme that helps to transfer it back to IDL, which is kind of our can serve as a precursor for kind of recycling and going through this process again, or bringing it back to the liver. Or we can have reverse cholesterol transport, in which the HDL comes by, picks up the cholesterol, and then takes it back to the liver. And when we have the IDL or LDL or the cholesterol from HDL that's brought to the liver, we can either use this for the synthesis of bile salts, which can then get re-recycled, or it can be excreted in the feces. Okay, and that's all I have for you today.